Welcome to the inaugural Joan Whitelaw lecture. The session was chaired by Irene Oldfather from the Alliance. The speakers were Henry Simmons from Alzheimer Scotland, Maureen Bisognano from the Institute of Healthcare Improvement, and Tommy Whitelaw from the Alliance. This recording was made on 8th of June 2021.
So good afternoon, everyone. For anyone who doesn't know me, my name's Irene Oldfather. I'm Director of Strategic Partnerships and Engagement at the Health and Social Care Alliance, and it really is a huge privilege for me today to be chairing this session, which is the inaugural Joan Whitelaw lecture. And I've got a little slide that's going to come up here, because I think it's important that we just know who Joan was. There can hardly be a person across Scotland and even the globe that doesn't know the story of Tommy and Joan, but I wanted to set the right tone today by just looking at these photos of Joan as a mum, Joan as a wife, and I had the sad but honour and privilege of attending Joan's funeral, and I heard a little bit about her story there of how she was brought up and had a very close relationship with her sisters, how she met and married the man of her dreams and her love for all of her life, Tommy's dad, and how she was a mum to three amazing children. And being a mum myself, I just cannot imagine the kind of compassion, the inspiration that she brought that would result in Tommy and the work that Tommy has done to commemorate life letters and love stories and that relationship that he had with his mum and with his dad and with his whole family, and the importance of kindness and love in the stories that we have. And today is a bit of a celebration of that, because I suppose common cause that brings us together today is the fight against dementia and Alzheimer's, and sadly that influenced the sunset of Joan's life. But from her life and from her death, there's a legacy of that love letters and life stories that Tommy's been working on over the last 10 years. There's a legacy of kindness, care and compassion. And that legacy has touched every bit of Scotland and has made a difference across Scotland and the globe, and I know that. And that's a testimony to the two amazing speakers that are joining us today for this first Joan Whitelaw lecture. And I'm joined by a good friend and colleague, someone who has shown great courage and leadership actually over the last 15 years in his post as Chief Executive of Alzheimer Scotland, Henry Simmons, and we'll be hearing from Henry in a few minutes. And Maureen Bisognano, and we're so delighted that Maureen is joining us today from Boston. And I'll say a little bit more about Maureen when I introduce her later on, but she is a President Emerita and Senior Fellow from the Institute of Health Improvement, and I know has worked closely with Tommy and been impressed by that story of Tommy and Joan and how it influences and changes and makes a difference and has made a difference. I feel hugely privileged to have been a part of that and to be able to chair today's session. After Henry's talk, we're going to open up to any questions, and then we'll hear from Maureen, and then we'll open up to any questions on her talk, and then we can have a little bit of a general conversation. Then I'm going to invite Tommy back in to wind up the session. So I'm excited about all of that. And just before we move to that, we have a little surprise podcast from someone who couldn't be with us today, but wanted to say a few words of introduction to the inaugural Joan Whitelaw lecture. So can we play that clip from someone who needs very little introduction because he's never off our TV screens these days, and that's our National Clinical Director, Professor Jason Leach.
Hi everyone, I'm Jason Leach, the National Clinical Director of the Scottish Government, and it's a great privilege to just record a short message for today's event with Tommy, with Irene, with the Alliance, with Ian, and everything coming together into this, let's call it a celebration, shall we, of the work of the Alliance, the work of Tommy Whitelaw in particular, on this journey towards a more human rights approach to patient and family and carer involvement in their care and in the policy. I think change needs a number of things, whether it's this work that you're involved in or if it's been COVID that we've had to embrace over the last little while. You need the policy, so you need the Charter of Rights. You need to know what it is you're doing, the recipe for the change. You need a method. You need to know how you're going to do the thing. And Maureen Bisognano is speaking, and she is the method queen. She understands completely. She taught me the importance of that method. But the third thing you need, and I think maybe people forget this, is you need people. Real, actual people. You need people like Tommy. Tommy to tell the story of his experience. In his case, him and his mum's experience, and those who cared and looked after them and continue to look after Tommy even now. And each of us come with that experience of our life, of our loved ones, of our care. And that's crucial as we build. And it's particularly crucial coming out of COVID as we renew, as we make it even better. So I look forward to continuing to work with each of you, with the Alliance, with the coalition of partners from Alzheimer Scotland, from other parts of the system, both public, third sector and private sector, to make it better. But let's remember at the heart of that are people. And Tommy is just one example. And the work he's done has just been fantastic.
Thanks, and thanks to Jason. When we asked him, he immediately said yes, he would love to do that, although he couldn't come. So I think that was a lovely introduction, and I like the fact that he spoke today about a celebration. I think it is a celebration of years of work that Tommy's undertaken, starting with his Life Letters and Love Stories campaign. And I was one of the people that wrote Tommy a letter, and he took them to Parliament, and he's continued that work through his work now on intelligent kindness and compassion. And that's all arisen from the way in which he and Joan had to navigate and negotiate a very difficult system. And Jason's spoken there about change and the importance of how we make change happen. And so I'm really delighted that our first speaker is someone who has tried very, very hard and shown great leadership in turning around a juggernaut in Scotland. I'm delighted that we have our Chief Executive of Alzheimer Scotland, Henry Simmons, with us. I've actually known Henry even longer than I've known Tommy, so we go back a long way, but I've always felt that we've been kindred spirits with common cause in the work to highlight and raise awareness and change things around dementia. And I'm delighted that Henry also now is the Associate Director of Brain Health Scotland. And I think we're going to hear a little bit more about that in your presentation today. So over to you, Henry, and thank you so much for joining us.
I mean, thank you so much for that very, very kind and very warm welcome and introduction. And I suppose for me, it's truly humbling and a real honour to be invited to give this talk today. I've known both Irene and Tommy for a long time, and I'll never forget the phone call, Tommy, that was put through to me when you were first thinking about going on tour and collecting the letters. And I was pretty amazed and inspired at that point in time. And I think the work that you've done in memory of your mum since that point over the past decade has been truly transformational. And I think today we can reflect back on 10 years of progress and at points reflecting your part within that. So thank you for this opportunity. I'm just going to share my screen now, colleagues. I've got around about 30 minutes to just go through this talk today. And what I aim to do is to reflect back a little bit on where we were a decade ago and where we are now. I want to look at some of the real, developments, some of the real challenges and changes that we've come through. And then I do want to challenge just where we are and think through some of the the outstanding areas of practice that we've got to tackle. And as we go through that, I will hopefully start to touch on the way that we see the future, and then I'll bring some of that together with a new vision for how we take things forward in terms of our whole construct and paradigm around about dementia. So I'll just move on. Looking back, in 2010, I don't think it would be unfair to have described the way that we think about and the way that people living with dementia felt, to say that people had a lack of control, that there was a very high level of stigma. We had, in the main, a medical model of approaching, support people with dementia. And there was still a significant level of discrimination. The rights-based approach hadn't really taken hold yet. And I think that there was a strong voice, but a lack of voice across our society for people living with dementia. But there's a few groups and a few bodies and a few things that I think happened that really helped change that. So right at the core of that is the Charter of Rights work. And again, that's another phone call I remember having with you, Irene, when we discussed the need for a charter, and you suggested that to me pretty early on in my time at Alzheimer Scotland, and then we worked together with a cross-party group and many partners to make that a reality. But two very, very important and memorable points in my career with Alzheimer Scotland emanate from the two phone calls. And I think the voice of lived experience has always been central to our work. The Scottish Dementia Working Group, the National Dementia Carers Action Network, which both Irene and Tommy were involved in establishing along with ourselves, and then Tommy's work with Dementia Carers Voices. Now that has pushed our system away from that very sort of like medically orientated model to something that's much more attuned with a citizenship approach. I mean, our view, the way that we develop policy, the policies that have been developed now are all about the citizen. They're about the person with choice, power and control. They're about ensuring that people are included and ensuring that power is shared. And I think that's quite a remarkable but very visible transition in how we think about and support people living with dementia. And for that, there are many people to be thanked, not least those individuals living with dementia, those carers such as Tommy, who have been prepared to stand up, tell their story, engage in the debate, and really fight for the rights of many other people who came behind them. So I often say this, but we stand on the shoulders of those giants that have gone before us and delivered that for us. So that's a huge transition. When we think behind that, what we've also seen across the decade is quite a significant investment in people and in leadership. So some of the new roles that have been developed, some of the investments that have been made, some of the teams that have developed. And this is just a little flavour of some of that, yeah? So we've seen, the evolution of things like Alzheimer Scotland dementia nurse consultants in every NHS board. We've seen the specialist dementia improvement leads in more recent years developing to focus on transforming specialist dementia care units. We have over 1,000 dementia champions. We've developed the Focus on Dementia team now within Health Improvement Scotland, our allied health professionals. We've got thousands of dementia ambassadors. We have 36 dementia advisors. We have a handful of dementia practice coordinators, which is part of the problem I'll talk about later. We've got, somewhere in the region of 90,000 dementia friends across Scotland. We've got digital leaders, and we've got 70, 80 to 90 light workers. None of these things were in situ 10 years ago. That's a lot of investment, it's a lot of people, and it's a lot of leadership. And they're all about supporting people living with dementia, their families and their carers, but they're also all about change, and they're about supporting change and supporting the evolution and progress of dementia policy in Scotland. And then behind that, colleagues, we've developed some truly world-leading policy. Of that, there is no doubt. So just move this a little bit. If you think through some of the big ticket stuff from our perspective begins with the Charter of Rights, okay? But what's evolved behind the Charter is national dementia strategies. The Charter was at the front of the strategies, and the strategies themselves, I think, have included some very important approaches to transforming care. So things like the 5-pillar model, things like the 8-pillar model have all been a component within the strategies. connecting people and connecting support, pushing forward our allied health professionals, again, part of the strategy, promoting excellence framework, the subsequent development of the champions that I mentioned earlier. And more recently, our work to push forward in terms of primary care transformation. I think that's a really crucial point that comes into some of the work we're doing in terms of prevention and brain health. Some of you might be less familiar with a document called the Edinburgh Consensus that was produced in Scotland a couple of years ago now. And that's a really important, national agreement between scientists and practitioners across the UK about how we can move forward to ready ourselves for prevention, to ready ourselves for the type of drug discoveries that we heard about yesterday and celebrated yesterday, and I'll say a bit more about later on. So behind that, I think Scotland's also played a role in a European framework. The Glasgow Declaration that was delivered and signed at the Alzheimer Europe conference, several years ago now, was the first time that at a European level, our work and rights and a rights-based approach was put front and centre. And I think our colleagues at Alzheimer Europe would graciously accept that so much of their work in terms of involving people with dementia, taking a rights-based approach, has been influenced by Scotland. So, colleagues, something to be truly proud of, world-leading recognition for Scotland within the policy, development and evolution, and indeed delivery. And I believe that, across that, where we are now, again, we're leading something pretty special through our work in prevention and brain health. And I hope that we will continue to do that over the next few years. So just moving on, this and working in any change system, I think the first thing that you have to learn is you can't do it on your own, and you're not going to do it on your own. And you need to be encouraging the evolution of, new ideas, new organisations, new approaches. And we've really enjoyed working so closely with a broader array of partners and emerging organisations. Now, some of these organisations have been strategically invested in, such as the Alzheimer Scotland Research Centre, the Policy and Practice Unit at UWS. Some of the work that's been done to see the development of the Scottish Dementia Research Consortium, for example. But other sort of developments have been through, people locally on the ground thinking through what might work best for people living with dementia, what might be different, and things like football memories, Pass for All, Playlists for Life, Hearts and Minds. I've got here obviously dementia carers' voices. These are all really important parts of the system that's been created to just drive forward change within Scotland. And I think that I could probably put 100 more smaller local developments, local initiatives, local groups, and indeed more national groups perhaps onto that. We've also got the Centre for Dementia Prevention, which brought a huge research focus to Scotland, and indeed Joint Dementia Research is a programme we run. So I think it would be fair and safe to say that across Scotland over the past 10 years, we've had a wonderful transformation from a rights-based approach, from a more medical-based approach to a rights-based approach. We've developed significant investment in leadership. We've developed world-leading policies, and we've done that as a collective group across Scotland with a whole array of emerging organisations with a strong, high level of commitment and dedication to people living with dementia. You would think that given all of that, that we would be able to ensure that every person, every time throughout Scotland receives the same high quality standard of care from the point of diagnosis to end of life. And I'm deeply disappointed to say that is just not the case, colleagues. And I think it's quite unimaginable to think that's where we still find ourselves talking after 10 years of what I've just described. So what's happening there? Where are we getting this wrong? So our reflection on this, colleagues, is that we have a great national focus. We can develop national standards and we can develop legislation. We can look at prevention and brain health and public health. We can even have a national debate and focus our fair dementia care work within, quite a straightforward context. And it works well. and it has worked well. But the scales are very much imbalanced, because when you look at the local issues, things you really need delivered to give you that consistency, delivery in terms of diagnosis, post-diagnostic support, integrated care and advanced care, things just seem to start to go wrong. And we've spent a long time trying to understand that, and indeed trying to influence that. This model here, we've worked on this vision now for several years. And what we've been trying to do as an organisation is to take the collective movement and the power of local voices to engage and enable people, and indeed to sort of like ensure that the sort of national perspectives are reflected in that local engagement, and to try and ensure there's a path created that's got early diagnosis, post-diagnostic support, integrated care and advanced care all the way through every local area. And wrapped around that are work in general and specialist hospitals and healthcare, and indeed beneath that, this desire to create a dementia-friendly Scotland. And you would think that it isn't too much to ask that each local area has a strategy for delivery based on a vision such as this, or indeed a vision, that might be like, more broader than that from the national dementia strategies, because this is an Alzheimer Scotland vision. But this work's been adapted with focus on dementia. It's been supported by national government. It's seen to be a reasonable model. And we look to get that implemented locally. But colleagues, this is how it looks locally. It is like a broken jigsaw. And we are seeing this even more now, as a result of the pandemic. But prior to the pandemic, it was very obvious and very clear to us that so many people weren't receiving a timely diagnosis. So many people were actually having to wait substantial periods of time to get access to our link workers, despite it being a guarantee for every single person. Our improvement work in terms of testing the 8-pillar model and advanced care models, really high quality work, works really well in the areas that's been supported, but getting the spread, getting the engagement, I'm sure the stuff that Maureen will talk about later, getting the system to change, and for local areas to really deliver a focused dementia strategy across the whole area, rather than just a little component of it. That seems to have been our most significant difficulty in the past 10 years. And we think that there is a core fundamental problem here. And local democracy and integration just has not really worked well for people living with dementia and their families. And there seems to be several reasons for that are quite clear, but a little bit hidden. So when we look into local policy, when we look into local plans that are being developed, dementia is often boxed into either an older person service or a community mental health service. And it's commissioned in ways that are quite, different across the 32 areas, but also quite strange that we don't have and we don't see locally a sort of like a replication of the national dementia strategies and an implementation strategy locally to be delivered that's in line with these strategies. What we see will be, a commissioned day service, perhaps some other group or some other form of commission in terms of link workers. We'll see home care being commissioned perhaps on scale and not really being part of a dementia specific or specialist approach. So there's a real disconnection in our view to the national visions, the national strategies, to local delivery. But there's also a problem there because we've got national strategies and we've got national strategies agreed, but who's accountable for that? Where does the accountability truly lie? So we've spent a long time really working very hard, very diligently to build up all of these strategies. We've brought that voice of people with dementia, we've brought the engagement of family carers, we've built a consensus across all the organisations and all the individuals and leaders about where we're going. And then we try and implement it, and there's no accountability, there's no governance structure within that. We pass things over to local areas. And I'm sure you all will know and agree, localities are very busy places, and you have a proper voice, they have a strong influence. you have to work really hard. Alzheimer Scotland would probably need to spend all of our fundraised income, not in things like dementia advisors and resource centres and nurses or research. We'd need to spend it all on policy officers to make a dent in local IGB engagements. So really, I think that it's only fair and reasonable to say a condition with the size and the scale and the extent of the number of people living with dementia in Scotland can't be delivered in this way. We have to think about a change. We have to really try and move that forward. So for us, the solution, or what part of the solution, is really being added to by this discussion about a national care service. And we firmly believe that it might take 3, 4, 5 years to consult and develop and engage with a national care service. But we would very much like to see there be a team and a directorate firmly established within Scottish Government who have a budget, who have the ability to commission, who have the ability to work with IGBs to agree on a plan of delivery for that national vision. And we would also like to see within that a much deeper depth of accountability and governance to ensure that these plans are getting implemented. At the present time, there's great engagement with stakeholders, there's great engagements within a whole raft of forums, all really people who have been committed to developing the plan, but none of them with a responsibility for delivery or accountability to that. So we've got to change that. We can't run these wonderful systems and strategies and policies without some form of local delivery, some form of measurement, some form of accountability. We get information just now that's 2 years behind about stats and delivery, and we're always working to try and, catch ourselves back up rather than have direct lines of governance and accountability. So we've been campaigning, across Dementia Awareness Week to make these points and to argue that this system needs to change, that one thing we've got in Scotland is a really big opportunity to prepare for the National Care Service. And I would say to you that the dementia team within Scottish Government are a fantastic team, but they're a tiny team. It used to be the case that dementia would have been a paragraph within a mental health strategy. And that was prior to 2010. And in a sense just now, the team we've got in Scottish Government is almost like a paragraph in a great big book. They're really small. They need support. We need a directorate to deal with the issues and support for people living with dementia, and indeed to move forward in terms of brain health. So, colleagues, I think that we now need to get into a much more, open and honest dialogue about the fact that, let's not miss any more opportunities. We still have some fantastic policies. We still have some fantastic areas of work. We still have some fantastic people and organisations. But, now's the time to use the opportunity with the National Care Service debate to just take a bit more control and give our local authorities and IGB some support through some additional funding to start to get this right and to get a more strategically better controlled, better shaped and higher level of accountability in terms of delivery. So we will keep on that, and any support that you might wish to give us and support with us, we'd be more than happy to welcome and receive. So thank you for that. Now, what we have now done is we've developed this new vision, and I suppose, in advance of the National Care Service, we think we need this. The National Care Service needs a dedicated dementia directorate with a budget. We've lived with, the acceptance that there hasn't been a lot of money for the past decade. I understand, and we understand that, and we've always wanted to make the best use of the funding that was there. We spend billions of pounds in dementia care, but it's very, very disjointed. And we think that actually now's the time to bring together a strong budget, a strong level of investment. We can't expect local authorities within their current resources to deliver on everything that will be needed to get people through and recover from the pandemic. If you get an opportunity to read our report in terms of the hidden cost of the pandemic and people living with dementia, it is significant. We have basically moved everyone forward almost 3 years. Individuals who were in the early stages have progressed significantly. Those that were in the mid stages have moved to the later stages. And what we're finding just now is a community of people living with dementia who are on their knees, colleagues, and who, if we don't help and we don't start to increase the level of support, we will see significant crisis that we've never seen before. And the only way to support that, in my view, is to actually give the local authorities some support. We do not want to get into a debate to say you're not doing enough here when we know they don't have enough to do it with. We need to get extra levels of support, and that needs to come from a national perspective, and that's why this dedicated budget is required. So you'll see here, colleagues, I've added into this vision our approach to prevention in brain health. And this model, we hope, will be something that the community can get behind and can support, but we still have to see that delivery in terms of local implementation. So let me tell you a little bit about prevention in brain health. So Brain Health Scotland, we started working on this a few years ago now. We were very fortunate. Craig Ritchie was leading the Centre for Dementia Prevention at Edinburgh University. And Craig and I were working closely to support the Scottish Dementia Research Consortium and the Scottish Dementia Informatics Partnership. However, we were quite clear that the most important change in our understanding about prevention probably came about sort of 4 or 5 years ago, when the Lancet Commission produced evidence that 30% of dementia is potentially preventable. And that really focuses on, developing an approach to dementia prevention that is about brain health and about earlier intervention. So Craig and I worked closely with government. We managed to sort of get the support of the First Minister, and we agreed the setup of Brain Health Scotland. And Brain Health Scotland is hosted by Alzheimer Scotland. It's grant funded by Scottish Government, but Alzheimer Scotland contributes a substantial amount of in-kind resource to make it work, and it's part of our governance structure. And these are the 4 key objectives of Brain Health Scotland. Basically, we're not trying to create a great big institution and a great big organisation. We're trying to create a really focused and something that can really direct to the key areas that need to change. So we want to bring the clinical, we want to bring the research, we want to bring data, we want to bring practitioners with us, and we want to bundle all that up, and we want to take it 15 years forward. Okay, so we want to jump, all of our thinking, all of our approach about how we engage with people in terms of dementia, and take it forward 15 years. And behind that, we want to get Scotland research ready. We want to get Scotland highly sort of focused in terms of preventive work, and we want to make our primary healthcare system start to deal with people with dementia much, much sooner and in a different way. So I'll just move to our next slide. This is a sort of population pyramid that we're looking at, and some of the activities that will be taking place within that. So at the bottom of that pyramid is our general approach to public health, which is about activities, awareness raising, education within schools, and indeed general policy. The next level is our engaged population, which is people who perhaps have got family members, people who are concerned or worried about their memory, people who might have a potential risk factor being identified, and that's a target group for us in that second tier. And then the third tier is to create this structure of a brain health service and ultimately some brain health clinics. Now, what this looks like in terms of a care pathway is this. I'll just check. I think I still got about 5 minutes, Irene. Is that okay? Yeah, I can see. Yeah, you can let me know if I've run out of time, but I think I've got 5 minutes. So, colleagues, this is a really, really important and exciting development for us that we've been working on for the past year. But it's made even more important by yesterday's announcement about aducanumab. That new drug is the first drug that we know has an impact in amyloid and can cleanse the brain of amyloid. Now, it might be that that theory is not correct. It might be that the drug manufacturer Biogen have got that wrong. But if what we think that Alzheimer's disease is caused by the amyloid protein that leads to the sort of like if you like, the spread of the fire in the brain, yeah. And if this drug can put that fire out, then that is a seismic change. There is a concern that it doesn't put the fire out, but it just blows the smoke away, and that the amyloid is actually a reaction to the other disease processes. However, we will know that soon enough when this drug is getting used in a widespread fashion. So I say that in the knowledge that drug discovery and creating a system where that drug could be utilised fits in with this pathway perfectly. So we're looking to start engaging with people in a much more open doorway, using our resource centres, using primary care facilities where someone might be getting in because they've got a high blood pressure or they might have another risk factor that we know about, and just get people to come in to do a little bit of risk profiling, to think about lifestyle factors, to think about potential comorbidities, and to think about going through some form of cognitive assessment. And at that point, getting some advice about how to adapt your lifestyle to prevent potential, development of diseases that might lead to dementia. So that's a sort of first level community engagement aimed at that sort of like second tier in the population pyramid. If people come through that and they're showing signs of concern, then we would be looking to get them, and part of the work of Brain Health Scotland will be to get them engaged in a brain health clinic where they'll get a more detailed assessment that will look more at this their cognition, their functions, and they'll do some blood sampling and some physical tests. And that would be like a first step into a brain health clinic. And this is the exact area where the new drugs and the new developments would be appropriate, because this is where people might have a mild cognitive impairment, they might be showing other risk factors or risk symptoms. And at that point, many of that group might just need a personalised risk reduction plan that's based on the algorithms that we know through the data that we collect that will work well to reduce people's potential risk. But failing that, some individuals might need to go for a consultant level assessment, and that's where you'll be getting the neuroimaging and a much more detailed genotyping. And from there, if people have a suspected dementia, they would then go to what we currently have in terms of memory clinics, or indeed we might run there that type of approach with that sort of more detailed personalized risk reduction, and keep an eye on people to make sure they're getting supported. So this new pathway jumps forward hopefully decades for individuals. And what that means for us, and what that means for Alzheimer Scotland, and perhaps what this means for our community is, do we need to rethink our whole construct? I mean, I would say, colleagues, dementia is the end outcome of untreated brain disease. And we're named after Alois Alzheimer, who told us over 100 years ago that actually this is a brain disease, and showed us at that point the very things we're talking about treating just yesterday and today. So moving forward, we will start to test this idea of our dementia resource centres becoming brain health resource centres. We'll start to consider how we engage with the public in a much more brain health orientated way, and we'll use our existing resource centres, of which there's some 23, 24 across Scotland, to start to build on these approaches and to start to engage with the community. And we'll test that, because what we don't want to do is we don't want the dementia community as it stands to feel that, in some way we're making a big transition away from that. We're not. We will never do that. That will always be our role. But I think looking forward for 10 years, colleagues, this is an opportunity. It's a seismic moment in time. It's been a huge day yesterday, and it's been really quite a wonderful opportunity to reflect on that today, particularly in memory of your mother, Tommy. And I just want to finish by saying thank you so much. Thanks for listening to this, and I'll pass you back to Irene just now for any questions or comments indeed. So thank you, colleagues. Thank you very much indeed.
Thanks very much, Henry. I mean, that was such a comprehensive analysis of the challenges that we've faced over the last 10 years, but also looking forward to some of the prospective solutions and some of the areas where we need to continue to work together to raise that awareness. And I'm very intrigued to see this new idea about the brain health resource centres within communities, because I think we know that that's where people want to be. They want to be in their local communities. They don't want to have to travel miles away. So having that kind of transition into local communities seems to me like something, a great opportunity there. And we've been getting lots of comments in the chat line, and when Henry, you were going through, all of the initiatives, that have been really overwhelming, the work that's being done, but still people feeling, I'm still exhausted, there still is that disconnect that you talked about, Henry, and people are saying in the chat line, I'm still feeling it, and it's exhausting. So I hope that maybe this offers an opportunity for us to sort of coalesce around something that can actually make a difference to people. Now, we do have some questions in the chat line, and I'm happy to take a couple of questions or any short comments before we go on to Maureen. I'm aware that the afternoon's running away with us, but it's so interesting. I suspect there's a huge amount to talk about. But there was something in the chat line, Henry, and I'd be interested to know your thoughts on this about, how important is it that the third sector, what can be the third sector's contribution in achieving the objectives of Brain Health Scotland? And you spoke about the importance of moving away from only medical models. Clearly, this is a sort of it's a combination, and I wonder, are we able to have the diagnostic infrastructure to underpin it, or is that something we have to continue to work to sort of challenge and raise awareness? Because you did speak about the importance of more resources.
Yeah, Irene. So I think there's two components to that. I mean, the first component is that if the third sector weren't there, all of the things that we build around about people in terms of post-diagnostic support just crumbles, and we've seen that through the pandemic. So, we can put in skilled post-diagnostic link workers that can help people come to terms with illness and work through that type of, very personalised support. But without our sector delivering all of the community opportunities for peer support and engagement, some of the fantastic social prescribing that's starting to be developed, I think that would really, that'd be a huge loss. However, what we need is something even before that. I mean, we're going to have to, think about, everyone, with a mild cognitive impairment, perhaps walking through one of the clinics can get access to a scan and a cerebral spinal fluid test. But we're doing some work just now to prepare for that. And then what we're going to have to think about is, like, aducanumab is not going to be a cheap drug, and we're going to have to make sure that people get access to that. And I think, we're back into like a little bit of a medical approach because it is a treatment, so I think that we have to have this balance all the time of not devaluing that approach to treatment, and at the same time equally valuing the support that the third sector is here to provide. So I think that our goal would be that the two things don't have that imbalance scale, would become equal, with equal importance. The other thing that I think the sector could do to help us is to support a collective movement, not a disconnected movement. And often what happens is that, you will see sort of like, potential sort of differences of opinion, differences of view, absolutely fine. But I think our collective voice is much more important than small differences of opinion. And I think that too often I've seen people facilitate splits in our sector because it's like, that's the big national organisation, that's this, and frankly, I just think all of that just becomes noise and we lose our way. So I think a collective agreement about, that's a vision that we want to share, that's got room for everybody. Do you know what I mean? We don't need to be sort of allowing ourselves to be either split or dispersed by others within this, but be coming together and stronger and ensuring that approach, that rights-based approach, is absolutely the right way. Yeah.
Thanks. In the chat line, some great comments about how you're giving us hope and things to concentrate on, and I absolutely echo what you say, Henry, that we will do far better when we work together on these things rather than worrying about artificial boundaries here and there. So you can count on us. We're absolutely up for supporting you in that challenge and working with you. And I was delighted to see the setting up of the Brain Centre, and was very supportive of UWS and Edinburgh, Craig and Debbie's work around this along with yourselves. So that's great. I think what I'm going to do now, because there's been lots of compliments in the chat line and comments that people can read, but I think what I'm going to do is move now to Maureen. And we've already heard some comments. I heard Jason saying there that he learned what what he knows from you, Maureen, and that you are the method queen. So, you know, you are the person that we now want to talk to about how do we do all this? How do we rise to these complex challenges, and how do we work together? But Henry, can I thank you so much?
Well, thank you.
And we're gonna, you know, there may be some time at the end just for a little bit of conversation. So don't go away anywhere, because we might come back to you. But Maureen, thank you so much for joining us today from Boston. You know, we know that you bring expertise in such a huge range of areas, and you know, I'm just looking at your CV, and as well as being a former IHI president and CEO, that you've been working at Harvard, you're a research associate in Brigham, and you know, that you've been working on health inequalities, and that you're a global leader in person-centered care and what matters to you. And of course, these are things that really speak to our hearts, and that person-centered approach that Henry's been speaking about there too is so important to us. So I'm really looking forward to your presentation. So without any further ado from me, Maureen, over to you, and thank you so much.
Oh, thank you, Irene. And Henry, thank you so much. That presentation was amazing and inspiring, and I feel hope. And you laid out the challenges in such a very practical way that I really am inspired by what you're doing. I'm going to share my screen here, and is that okay, Irene? Can you see that now?
Yeah, perfect.
Okay,
yeah,
great. And Tommy, thank you for the invitation. Tommy, the first time I met him was probably 6 years ago or so, and I think our friendship has bonded over our shared passion for what matters most. So that's what I wanted to talk about today. And I thought I would share a story about why I care, and it's about my mother. And I'm the oldest of 9 kids. So when everybody comes to my house for, you know, an annual festival or whatever for every holiday, there are 58 of us in our immediate family, big Irish family, as you can imagine. But my mother was the most incredible person, and all the grandkids loved her. She was just the mother of our whole family. I took this picture on her 78th birthday. She came to visit IHI, the Institute for Healthcare Improvement. And my mother used to make quilts for a hobby. And so I had them framed and put them up on the wall of IHI. And my mother stood there at her birthday celebration, and she cried. She said, "I've never thought about myself as an artist, you know." She said, "I always just did this for a hobby," but now she's seeing her work. About a week after I took this picture, I found my mother unconscious, and she had had a stroke. And we brought her to the hospital, and the experiences of being in the ICU really reinforced that we have so much to do about changing healthcare from being scientific only to being humane and compassion driven. I remember after about a week, my mother was intubated, had all kinds of lines and all. A doctor called a meeting for our family, and because our family's so huge, we had to have it in a big meeting room. And the doctor sat down and he said to us, "Tell me about your mother." And I said, "She's 78 years old. She's had bilateral knee replacement. She has diabetes." He put his hands up and he said, "No, tell me about your mother." There was silence for a moment. And then one of my younger brothers, one of the trouble ones, he said, "She always loved me best. She used to tell me that all the time." And we all started laughing. And we told for an hour stories about my mother, laughing, crying, everybody bringing her memories to that doctor and nurse who were taking care of her. Then another doctor came in. And he stood up, he didn't sit down, and he said, "I'm going to have to do a trach. We're going to have to find a nursing home that takes care of patients with feeding tubes." And he was all clinical. And then after a few minutes, he looked at his watch and he said, "I have to get back to work." And my brother, the troublemaker one, he's very funny. He said to the doctor, "Do you mean that because my mother is this sick that she's not your work anymore. And at that moment, I said to myself, and then I said to the first doctor, you're the doctor for her soul. And the other doctor, you're the doctor for her body. And the two were so separated, so distinct. I said, we need to work together to bring this together so that my mother never has to, when she can't answer a question for what she wants, that we all know what she wants. The CEO of the hospital came up to me that day and he said, is there anything I can do for your mother? He and I have known each other for many years. I said, no, there isn't. And he said, is there anything I can do for you? And I said, yes, you can unlock the door between my waiting room and my mother. And he said, no, it's not locked. So I brought him up and we looked at the door. The door says basically, stay out, authorized personnel only. Please call. If we may answer, we may let you in. And every morning, the nurses would cover the windows over with paper so that you couldn't even look in. I felt like my mother and I, all of us and my mother were separated. And I said to the CEO, this is not right. She's my mother. I need to have access to her now and always. And when I went back a few days later, all the signs were down. The door was open. It totally changed when I was able to tell him what mattered to me. So that was some years ago, but we still have lots to improve. At IHI, we said we can't only work on cost or population health. We need to understand the experience of care. And we need to hear the voice of patients and families so that we can get to the Institute of Medicine's aims for a better system. So COVID has, I think, changed a lot for us all. And for me, what it's done is really reinforce the need that we need to innovate and spread. As Henry said, we're seeing innovations, but we don't have a reliable system to assure that everybody has access to the same better care. So I want to spend a few minutes on ways to think about innovation and spread. As Jason told you, I'm like the tool queen. And so I'm constantly thinking about ways to innovate and ways to spread. Then I want to talk about exnovation. And if you haven't heard that word, it's getting rid of all the junk in our system that doesn't add any value anymore. We're terrible at it in healthcare. And then I want to talk about compassion. So innovation means we need new models. As Henry said, we've got little bits and pieces, but it's not a system. So we need to focus, I would say, an innovation lab or some new ways to think about redesigning processes. And then it's our moral obligation to assure that everybody gets access to the best care. The idea that we've got 32 different places and the processes might differ isn't right. As healthcare leaders, it's our job to step in and assure spread. And then we need to stop what doesn't work anymore. My husband says I'm terrible at exnovating my closet, but I'm really good at exnovating in healthcare. And we really need to develop expertise to stop doing things that don't matter, that don't work. And it does take courage because we're just used to opening the closet and sticking it all in there and saving it for another day. So a couple of examples. At IHI, we developed a leadership alliance. And we said, when you want to innovate, you need to radically redesign care. So we created these principles. And whenever someone's saying, I don't know how to innovate, I'll say, just pull out this list. I love the whole idea of the Brain Health Resource Center. That's flipping the balance of power. And it's saying, you're not a disease, you're a human, and we're going to work on your strengths. And I love that flipping. That's an example of this. Just before COVID, I had an opportunity to visit with Joost Blok, a nurse in the Netherlands. And what happened in the Netherlands was he was a home care community nurse, and they started to change the system. They thought it was going to save money by paying by task and by hour. And so rather than Joost going into a person's home and taking care of the person and their family, he now had to run around our bikes as we were riding bikes through Amsterdam, taking care of colostomy dressings, or things that RNs could do. And then someone else would come in the afternoon and do a bath, and someone else would come in and do an errand. It fragmented the care such that the joy in community nursing was totally wiped out. So he quit and he started a new kind of nursing care. He calls it Belzog, which means neighborhood care. And he changed it back so that a small team of nurses took care of a community. And they met every morning. I went and met with them in school cafeterias when they were having breakfast together. They not only took care of patients, but families and the team. And that changed to better outcomes and better healthcare. Costs are lower, huge opportunity to make savings when you flip the balance of power from trying to optimize a minute of care to optimizing a team and a family approach. So Belzog, I think, is now spreading. At Johns Hopkins in the United States, another community nurse, Sarah Zanton, used to go in to take care of elderly people, and she would bring her bag and draw the blood and do the meds, but then she'd look up and say, how can they live in this environment? And so she created an experiment. She called it Capable, and it's a team of a nurse, an occupational therapist, and a handyman. And the three of them go into people's homes. The handyman, it turns out, is having the greatest impact on keeping people safe in their homes. But the team also learned, because when they were leaving, they would say, well, what did you see? And what did you see? And they realized that the different professions have different perspectives. So it really produced much better, safer care at a much lower cost. That's an innovation that is now spreading all over the world. 3 times return on the investment, halved difficulties in function, reduced symptoms of depression, and improved motivation. And I think those are so important as we're thinking about the isolation that people are suffering in COVID. You may know Jen Rogers. I was flying to Paris some years ago to give a plenary talk. And on the plane, I read a journal article that said, we can't only ask the patient what's the matter, we have to ask what matters to you. And so I ripped up my plenary talk and rewrote it on the plane. And when I got there, I told the thousands of people in the audience, when you go back, ask the next person not only what's the matter, but what matters to you. And Jen, one of my favorite nurses from Scotland, did just that. She went back and she asked a little girl, Kendra, who's 7 years old, what matters to her. And Kendra has autism and she doesn't speak. So Jen pulled out a piece of construction paper, and Kendra and her father made this poster that said, I don't like medicine by my mouth, so I watch out, I'll struggle. It's a 3-person job giving meds. And I am very fast and I can make a run for it. I love cuddles. I can dress myself with some help. That evening, Kendra's father was taken to the adult hospital in Glasgow with a cardiac event. Kendra was by herself and didn't speak. But the nurses and the doctor said because this poster was on the wall, they understood her and they could care for her. They said if they walked in without the poster and she pulled their hair, because that's how she says hi, or she struggled with meds, or she ran, they wouldn't have known how to take care of her. They likely would have sedated her or restrained her. But because of the poster, they knew who Kendra was. So that started to spread across Scotland to Geraldine Marsh, who works in a geriatric hospital. And then the poster at the bottom is in Portuguese. I got it from Sao Paulo, Brazil. People all over the world started to say, when they ask this question, what matters to you, that it changes their perspective completely on what to do. Anders Verga, this says what matters to you in Norwegian, flipped a whole nursing home whiteboard. And I visited here just before COVID. The old way the whiteboard used to look was it had the patient's name, their age, their resuscitation status, their doctor, and a couple of other things. Now it's their picture, what they want to be called, what matters most, and then all the other stuff. And so I said to Anders, what does this gentleman want? And he said, oh, he's an 88-year-old man who wants 2 scotches every night at 5 o'clock. And I smiled when I learned that. I said, what about this lady? It, in Norwegian says in capital letters, never take me out of my room without my hair done and my makeup on. And so what you see here is I smiled as I began to know who these people were. They weren't diagnoses. They weren't DNR do not resuscitate. They were people, and it really totally changed the culture of long-term care in Norway. So it spread from Norway to Brazil, to Scotland, to Italy, to Canada, Denmark. And now, these years later, What Matters to You is in over 50 countries, over 2,000 teams have changed the way they practice from what's the matter, I'm going to come in, I'm going to take your vital signs, to what matters to you. And the change is really creating a culture of humanity and kindness that's making, I think, a huge difference. Every month, a group of people from around the world speaking different languages gets on a call. If any of you would like to join, we welcome you. And there's a new website called WMTY.world, whatmatterstoyou.world, WMTY.world. In Belgium, one of my friends called me and told me that he had heard about What Matters to You, and they took it a little bit in a different direction, but same principles. The woman on the left, Anime, is a journalist, and she does documentaries for the public television station. The woman on the right is a patient who had been in the ICU. And when the journalist went into the hospital, she kept noticing this woman. And when she finally was extubated and could speak, the journalist went back in and she said to her, tell me, what is it like? What has it been like in the hospital for all these weeks? And she said, the patient said, get in the bed with me. And the journalist hopped in the bed and she said, look up at the ceiling. That light is all I've seen for all these weeks. And she said, has anybody come to visit you? And she said, oh yeah, they line up the chairs along the two sides of my bed and they talk to me all the time. And she said, well, that's great that they're visiting you. And she said, no, they're all dead people. She was so delirious from the intubation that she couldn't really understand reality. She needed somebody to say, what matters to you? So the reporter said to her, what would make your day today good? And she said, I want a mango. And the doctors and nurses in the room took a little step backwards. And she said, so the reporter went out and bought Vivienne a mango, brought her a mango frap and a mango, and the joy that came on her face that moment changed everything. They called it a mango moment. So now mango moments are spreading all over Belgium because that is what mattered most to her. So I would ask you to continue to ask this question because I have been asking it around the world and the difference it's making is incredible. I was in a hospital in Wisconsin and I said to the nurses, can you introduce me to somebody who their life is different because of this? And so they brought me to meet an elderly patient whose name was Ethel. She was in her early 90s, and her husband had died the summer before, and she lived alone and had no family. So the nurses would go to her home, and her clinical condition was deteriorating rapidly because of isolation and aging, I'm supposing, but isolation in particular. So the nurses first went once a week and then once a day, and then they were bathing her and they'd put her up in her wheelchair and stick her in front of the TV. And one day, one of the nurses said to her, what matters to you? And Ethel said, I want a dog. And she said, no, I'm the nurse. And she kept saying, thinking that the patient was delusional. She kept saying, what matters to you? And she kept saying, I want a dog. After she did this for about a week, on the way to Ethel's house one day, the nurse stopped at the dog pound and picked up a dog. This is Ethel now playing her violin with her dog. Ethel now goes to the hospital several days a week and plays the violin in the lobby. She's taking care of other people, not being taken care of every day because someone asked her what matters to you and because someone got her a dog. So we've got all of these experiences. When you ask, it makes a huge difference. There's a story from California here where one of the residents was trying to teach the medical students to ask what matters to you. And they said, no, we're too busy. We can't do that. So the resident brought the medical students into it, said, bring me to the dullest patient on the unit. And they said, we know who that is. So this is an elderly woman who only speaks in one-word sentences. She's homeless. So she's been in the hospital for months. We have nowhere to send her. So we just go in and take care of her. So the resident went in and said to her, how long have you lived in San Francisco? And the lady said, years and years. So that's more than one word to begin with. And then she said, where did you come from? Ireland. When did you come? 1912. Have you ever been in the hospital before? Once for a broken arm. How did that happen? A trunk fell on it. A trunk. What kind of trunk? A steamer trunk. How did that happen? The boat lurched. The boat. Why? It hit the iceberg. She came over on the Titanic. This woman was a housekeeper on the Titanic who had survived that. And now people, because they don't know who she is, are calling her the dullest person on the unit. Once this happened, all the medical students were going in and saying, tell me about it. Tell me about your life. How did you overcome that? And all of a sudden, the interactions totally changed with this woman. And she became interactive, and everybody treated her as a person, not as a dull patient who only speaks in one-word sentences. Asking what matters makes all the difference in the world. In Norway, one of the nurses, they started to ask each other at the change of shift, did anything make you smile today? And one of the nursing assistants said, I was taking care of this man who was the most difficult patient on the unit last night, and he made me smile. And they all said, wow, how did he make you smile? Usually they fight over who has to take care of him. He said, well, I went in to take care of him. And when you say, I'm going to bathe you, I'm going to get you dressed, he starts fighting. But that morning, the nursing assistant went in and he said, what matters most to you today? And the elderly man said, I want to wear my blue shirt. And he said, why do you want to wear your blue shirt? And the man said, because that was my wife's favorite shirt. And she died 2 years ago today. And I want to honor her. So the whole time he bathed him and got him dressed in his blue shirt, they were talking about his wife. And when he got dressed, they said, he said, will you take me out? I want to tell everybody out there, all the other patients and the staff about my wife. And all of a sudden, he wasn't a difficult person. He was a man who was celebrating an act of kindness in that day. So as I travel around the world and work with patients, I find oftentimes people are talking about digital care, and they're talking about the people on the left, digital like in the computer. But I also want us to think about digital care as being this kind of digital care, touching patients and making a difference in the way that we interact with them. It's both, and we really need to not forget this kind of digital care. One of my senior as Irene was saying, I teach at Harvard, and in one of my classes, I was teaching about ventilator bundles and central line bundles and urinary tract bundles. And two of the doctors came up at the end and they said, you're talking about what matters to you, and you're talking about bundles. We need a kindness bundle. So they invented this kindness bundle, and they're now spreading this around the country to say, sometimes we get so overwhelmed when we're going into a patient's room that we really need to stop and structure how we're going to approach this so that we have both kinds of digital care. And one of my senior fellows at IHI has been doing a lot of research on basic acts of kindness. Basic acts of kindness can lead to faster wound healing, reduced pain and anxiety, and shorter hospital stays. We're looking here in the United States, there's a wonderful book called Compassionomics that is doing some research into the impact of compassion. And the simple question their physicians are studying, asking what matters to you, is producing amazing outcomes. An example, when an anesthesiologist comes out of the operating room and goes to a patient before they bring the patient in for anesthesia to the operating room, and they say, hi, my name's Maureen. I'm going to be your anesthesiologist today. They put their hand on their arm and they say, don't you worry. I'm with you every minute. You will not experience any pain. And after we're done, I'm going to bring you right back here and get you settled in this comfortable bed. That 40 seconds of interaction means that the patients are using less anesthesia in the operating room, and they're using less post-op pain medication. The actual length of stay is shorter and the costs are less. So compassionomics, when you treat people with kindness, we're actually seeing everybody win, and particularly the team that's working with them. So compassion, I think, is a critical, we're at a critical time in COVID. I think more than ever before, we not only need to ask patients what matters to you, but we have to ask our team members what matters to you. We have to really anticipate that moment of kindness can have a tremendous amount of giving. But a lot of people are telling me that in this time of stress, they're so worried about the clinical care that they're not having enough time for this. So at IHI, we developed not only PPE, personal protective equipment, but psychological PPE. And I'm asking everybody when you think about your week, when you're planning your week, to not only work on figuring out your schedule, but work on your own psychological PPE. I would say every Sunday night, make a list of how you're going to work on your IQ. What are you going to read, or what are you going to do? What are you going to watch, or what are you going to write? People are saying, I'm too busy, but we can't leave our intellectual stuff behind. So work on your IQ. Second thing on your Sunday night is work on your EQ, your emotional quotient. Ask somebody what matters to them. Take a journey of a patient, understand what they're going through, just like you are. And then work on your CQ, your curiosity quotient. It might be sitting with your family on Sunday dinner and asking everybody, okay, Sunday nights are going to be what mattered to you dinner nights. And we're going to really explore what everybody's going through here. So you might ask your family, you might ask your team what matters to you. Ask your patients and the staff, and then ask yourself what matters most to you, because I do think you've got to take care of yourself. I always say you can't give what you don't have, and we need compassion and kindness for ourselves in order to give it to everybody else. So this is my thank you, and down at the bottom is the link to whatmatterstoyou.world, and I so appreciate the invitation to be with you here, and I think we have some time for questions and answers.
Thanks so much. Thanks so much, Maureen. You won't have time. You won't have had time to see the chat, but it's been amazingly complimentary, and people have so valued the richness that you brought to the discussion today. And some have been sharing their examples in their own way of some of the things that they've been doing. Certainly there are some people wanting to join your sessions. I've noticed that. That invite is very welcome. So just generally speaking, everyone's talking about what a great session this has been. And we also have a few questions in the chat, and actually you touched on some of it, and Henry, I'm happy to invite you to comment as well. But one of the questions is around how do we encourage health professionals? How do we get these messages across? Because we all know that, and you talked about it as well, Maureen, that everybody's busy. How do we get the value of these conversations? What can we each do to encourage health professionals to use frameworks like what matters to you? And someone in the chat lines also talked about getting to know you and kind of similar things that are really about seeing past the hospital gown to the person themselves. And you so eloquently described your own experiences around that. And I do remember someone telling me, who was a professional, a lawyer, that when she went into hospital and took off her suit and put on the hospital gown, suddenly she felt so disempowered. She wasn't that competent person that was in charge of things and an office and staff and everything. All of a sudden she became the patient, where things were done to her and not with her. So how do we spread this word, and how do we encourage? And I suppose alongside that, one or two people have been saying, and Henry, I guess this is around post-diagnostic support and link workers too, that often in communities, training around things like this can be seen as the kind of softer, more optional stuff. You know, how do we make it integral? How do we get the importance of this over as part of that holistic approach? And I don't know if either of you get any thoughts that you'd want to comment on around that.
Well, I'll start, but then I really do want to hear your thoughts, Henry. So two things. One, people are always afraid for two reasons to ask the question. One is they think they're not going to have enough time. And two is they're afraid that the patient is going to ask for something that they can't give. You know, like I want a new house or a new car or something like that. What I would say is as Jason said, use one of the quality improvement tools. You do a plan, do, study, act cycle. Ask one person. You will learn from that. And then ask another person. And then you can gradually build a new way to think about your day that actually includes it. And I do think that leaders need to demonstrate that they care as well. I'm seeing leaders now asking staff members what matters to you, and the changes that they're making are making a huge difference. Like, I don't know in Scotland if you have had any Project Wingman clinics. Is that familiar? One of my colleagues in London who I work quite a lot with is the CEO of one of the Royal Free. And she was working with the pilots and the flight attendants from British Airways when they got furloughed in the beginning of COVID. And so the pilots and the flight attendants went into the hospitals and they set up first class lounges, like British Air lounges. And 24 hours a day, the pilots and the flight attendants are staffing them. And a staff member who perhaps is going through really challenging shift with losing patients and dealing with families and putting PPE on and off, they'll go into the lounge to have coffee. But those people who are experienced in dealing with stress will coach them and help them through that. That's saying, what matters to you? I'm fried. I am just exhausted. Well, go get some coffee and we've got somebody to take care of you. And I think those kind of examples, we're seeing compassion teams, we're seeing all kinds of leaders asking and then doing, and that's making a big difference. Henry, what do you think?
Yeah, well, so first of all, can I say I was so inspired by your presentation, Maureen. It was tremendous, and I learned so much there. I don't even feel able to comment too much on this, given your experience. But I suppose for me, a reflection that we've had within the dementia community for a number of years now is that a lot of our colleagues in various sectors have got what I would describe as a damaged psychological contract. And I think that they're working in environments that they never expected to be working in. They're working under stress and pressure that they never expected to be working in. They're working, in social care in particular. And I'm a member of the Fair Work Convention, did a big report on this. They're underpaid, it's not secure enough, they've not got an effective voice. So these are all ingredients, I think, to really have quite a damaged psychological contract, yet they still manage to go out there and try and do their best. And I feel that what we tried to do when we set up the Dementia Champions program, which was a training program that's really detailed, delivered by University of Western Scotland, but it gives people the opportunity to just come to get some space to understand and learn to really embrace what's possible in terms of someone living with dementia, to get a real, make a transition through that and cross a path that helps repair that damage, and often, and I think we as an organisation have very deliberately not tried to be an organisation that just throws in bombs and tells people how bad they are and tells people how bad things are, but to actually have sort of positive initiatives like some of what you've described, some of what we've been trying to do, to just really, work so much more closely with people. I don't think anyone will sit on a Sunday and say, I'm going to go out and do a bad job tomorrow. I don't believe there's a single health or social care practitioner probably anywhere in the world, but certainly not in Scotland, that would do that. So it's a system, in my view, that stops them from being what they could be. And we need to work together to just overcome that, I think. So, and I think we've got some good examples of it and some really brave people that have made that transition, man.
Yeah, I so agree that it's the fear, and right now the stress of COVID that I think is stopping people. So I would say, you might start with your family, or you might start with your team members. Did anything make you smile? Or you might start with one patient. And then, as you say, I think particularly some of the examples that you gave of pulling all these pieces together could allow us to start to map out a system of social change.
Thanks to both of you. And it kind of reminds me of when we were doing the business case for Life Changes Trust, and we sort of asked people, what would make a difference in their lives? We asked carers, and we expected, and I expected, one of the things they would say was more respite care, which is always a challenge, and it makes totally logical sense that that's what people would say. And having been a carer for my mum, I understood that, and I kind of thought what we hear from people is what we need is more respite care. In fact, I was surprised, because what they said is what we would absolutely love would be more places to go for joint activity, where we don't feel judged, where we can go together. I can go with my partner, my spouse, my mum, my dad. Nobody's measuring or judging, social etiquette. And Tommy and I did a radio program one time, and someone phoned in and she said, I don't take my mum out anymore because she has this habit. If we're out and we're in a cafe, she takes her false teeth out. And it just told me something about us as a society, that people feel judged and they can't do things like that. So it is so important to ask the question. And Tommy and I told her to go to the cafe and not worry about that. And the rest of us in society need to adapt and adjust and be a little bit more flexible in approach. But thank you both. I'm conscious of the time, and I'm wanting to bring Tommy back in a minute. But there were just a couple of other points. One was, and you touched on it, Maureen, around, how do we involve this, what matters to you framework within a digital context? I guess COVID certainly demonstrated in Scotland that, we had to move to near me, and, digital appointments were very much the thing. And as an organisation, we did a huge engagement exercise asking people about their priorities and coming out of COVID, what mattered to them, and how they wanted to see services restarted. And many of them had good experiences of digital consultations, and particularly for carers, they didn't have to get on 2 buses. They could be in the room next door to the person that they were caring from and have a consultation with their doctor. But one of the areas that was flagged up as a very difficult area around digital consultation, that was mental health. And people with mental health issues told us that they didn't often feel comfortable with the digital environment, that they preferred a face-to-face consultation, particularly around crisis situations. So one of the questions in the chat is around, how do we evolve the framework in the context of digital? And I don't know if you've got any thoughts around that. And then my final point you might want to think about, because I'm going to close and invite Tommy in after this, is we've been asked what matters to both of you. Would you like, in closing, would you like to just say a little bit about what matters to you? But first of all, I don't know if you have any thoughts on that evolving digital agenda.
Yeah, so I'll start. I chair the board of an amazing mental health trust here in the United States called the Wellbeing Trust. And we're working on mental health and resilience in the country, especially in this time of COVID. We found some things are really positive about using digital technology for mental health. One is the number of touches, that you can have interactions with somebody many times during a day, as opposed to waiting for your appointment a couple weeks from now. And those touches are making a difference. So we're seeing new technology emerge where it'll ping you and say, you haven't been online in an hour. That's unusual for you, and those kind of things. The other positive thing is that people are seeing what's happening in their homes. And so that's making a difference in the clinical interactions, because it's not just you walking in and sitting in a doctor's office. They're seeing what's happening in your home, and that's making a difference. So there are downsides, but I'm also seeing upsides.
Okay, thanks. Thanks, Maureen. Henry, have you got any observations? Because I know you are very much involved with people at the front line, and you referenced that in your comments. How do you feel this is impacting on people with dementia?
So we've done a good bit of work in this area, Irene, and so a couple of big things. We launched a virtual resource centre during Dementia Awareness Week, and that's been a substantial investment for the organisation. But that's an opportunity for people who, perhaps are using some of our face-to-face resource activity and support to go and join in a whole raft of therapeutic group activities 24/7 a day. We'll build that in coming years, but I think one of my colleagues is online, they can give you the details if you want to see that. The other point in that is we researched the therapeutic benefits of that for people, and we got fantastic results. We used some really good measures. So my view is that there's a population of people who this is normal and every day, and they'll be able to engage in it without any difficulty. Then there's a population who we want to have volunteers that can go out and just help them get online. I don't think they want to learn to get online. They don't want to have computers in their house. But the interesting sort of correlation here is what we learned was not to ask someone, do you want to go online and participate in a football reminiscence activity? You ask them, what would you like to do? So it's a little bit like, what matters to you? And people would say, I'd love to have a chat. I'd like to talk about football. I like music. And you say, right, well, I'll make that happen. It doesn't matter how you make it happen. It's what you're making happen. So I think that when we stop talking about digital and start talking about outcomes, we'll probably be getting somewhere. So, and I suppose like you asked me to think about what matters to me. Yeah, I mean, there's so many things matter to me, but I think truly like bringing an end to the inequalities that we've seen in the past 10 years around fair dementia care is probably the most important thing that I've ever been involved in, and that probably matters to me most in my work just now and life.
Thanks so much. Thanks, Henry. Maureen, would you like to share a last thought with us?
I think what matters to me is really shifting the balance of power so that we're not just taking care of the clinical side, but that we're really redesigning healthcare so that we're taking care of the patient and the family and the caregivers. It's all a part of what matters to me.
Thank you so much. I just really want to thank both of our speakers. I think they've been amazing. To Jason for taking the time to make the podcast, to Ian and the Alliance for supporting Tommy in this inaugural Joan Whitelaw lecture. And I'm hoping Tommy's in the back then somewhere and can come to the front. And Tommy, I want to give the last few words to you, and I hope we've all lived up to your expectations. And I just want to say, and I hope I can say this without being too emotional, but I just do think your mum would have been so proud of you and so proud of today.
Well, thank you. Firstly, thank you to Irene for chairing today, and to Maureen and Henry for such brilliant, thought-provoking and inspirational presentations. I suppose just a couple of things on my mind. Someone asked me once, what did I learn about caring for my mum living with dementia? And what I learned is that people are amazing. In amongst the struggles and falling apart and the breakdown that we both had together, I learned that people, they're brilliant and they're beautiful. And if you just take time to listen to them, you'll learn so much. And that's why I'm so honoured to have three people that you host in this session today. And Henry's right, it started with a phone call. And I have to say, as a carer, Henry, on a pay-as-you-go phone call at the time, putting £1 of credit in my phone. When I called you about the walk, and then a phone call to Irene and Ian many years later, and introduced me to people. But I can't let today go without some thank yous. Firstly, I want to, it's Carers Week as well, and our world shrunk. It started off, the world was a place we were part of, and after a few years, Glasgow became our world, and then Donald became our world, then our house became our world, then my mum's bedroom became our world. And it's Carers Week, and we're all maybe experiencing over COVID what it feels like to be a carer. We're separated. So let's unshrink the world for people. Let's unshrink the world for people and make a place that we can all be part of. There's lots of people I want to thank here today. Thank you to Henry for answering the phone that day. Thank you to Maureen for teaching me and being such a great mentor, and to Irene, who's put up with me for 10 years. If there's any medals going, we should get one for Irene and Ian for putting up with me. But it started with that walk 10 years ago and the incredible stories of people. And along that way, you know, I've now engaged with nearly 250,000 people at talks, and I've met some incredible people along the way, from Sean Mayer, who's been an incredible friend, to the foundations of Dementia Carer Voices and Carer Voices with Irene and Ian at the Alliance, and the brilliant Laura, and now Jen, and not forgetting Ravina and Will, who played such a big part in that. And some incredible people who I know are on this call today, from Gillian McCauley and Lynn, and launching those first pledge trees with Fiona McQueen and Derek Marin in Ayrshire, and Paul Jebb and Jane Cummins down in England. Now there's 30,000 of them, but they're all stories. The letters were stories. The pledges were stories. The What Matters to You walls were stories. And thank you for two brilliant people sharing stories today. So what did I learn from caring for my mum? I learned that you are all remarkable, you are magnificent, and you all really, really matter. So thank you. Thank you for making today such a special moment in my life.
Hey, Tommy, thank you. Thank you for that. Thank you for being you and for the inspiration that I think you've brought to all of us over the last 10 years. So thank you all. Today we've finished just about on time, and I know it's a lot earlier in the day in Boston, Maureen, so I hope you have a good rest of the day. Thank you, Henry, and Tommy, thank you for the inspiration behind today. And I see in the chat line, you know, so many people saying, you know, how you've influenced and inspired them over those 10 years. So thank you for everything that you do. And this is a conversation that I hope that we will all continue. And I know that Tommy will continue his work with Maureen, and certainly Henry's made us an offer. And of course, the subject of our conference today is equally valued and equally connected. And so I think that's a brilliant note to end the session today. So thank you for all of that. And goodbye and stay safe. It's been lovely to meet you all today. And particularly thank you to our interpreters and to our subtitlers. Thank you all so much.